Greetings, future nurses. Today on Discussions with Dr. G, we will explore the dazzling world of endocrine pharmacology, where we humbly attempt to replace or suppress the body's very opinionated hormones. Because let's face it, when the glands go rogue or take a permanent vacation, someone has to pick up the slack. Spoiler alert, it's usually you, armed with a MAR and a stethoscope. Buckle up. From radioactive iodine to growth hormones for adults still trying to hit 6'2". This is your scholarly, yet sass-laced guide to endocrine meds. Every new grad and BSN student must know. All right, let's kick things off with thyroid, because if there's one gland that loves drama, it's this one. So hypothyroidism, your patient's thyroid is basically thrown in the towel, and now you, the nurse, get to play hormone fairy with levothyroxine, Synthroid. Okay? This is the med that turns you into a morning person, whether you like it or not. You've got to take it on an empty stomach, 30 to 60 minutes before breakfast, and here's the kicker. It's lifelong. No, I feel better, I'm done now. No, you're in it for the long haul, and don't even think about switching brands on a whim, because the bioavailability can actually change. I know it sounds like a pharmacy conspiracy, but in this case it's real. Now let's talk about the stuff that makes every nurse sweat. Med interactions. Levothyroxine and calcium supplements. Mortal enemies. If you give them together, you might as well be handing out sugar pills. I had this student once, bless her heart, who mixed up Synthroid and a calcium supplement on a med pass. The patient's TSH was all over the place for weeks. I mean, classic rookie move, but it's also a great teaching moment. Always check your med times and teach your patients to space these out. Oh, and keep an eye on that INR if your patient is on warfarin. Levothyroxine can crank it up, and nobody wants a surprise bleed on their shift. Now, if the thyroid's gone the other way and is throwing a hormone rave, we're talking hyperthyroidism. Enter thionamides, propylthiouracil, and methimazole. These are the party crashers, shutting down the thyroid's overproduction. But you've got to watch out for agranulocytosis. If your patient calls in with a sore throat and fever, don't just tell them to drink tea. Get a CBC stat. And then there's radioactive iodine. Sometimes the best solution is just to nuke the thyroid. Literally. But you have to warn patients about radiation precautions. No sharing utensils, flush the toilet twice, all that fun stuff. It's not glamorous, but it does work. And of course, you're still monitoring TSH like your license depends on it, because of course it does. All right, moving up the hormonal food chain here, let's talk pituitary growth hormone therapy, also known as somatropin. It isn't just for kids who want to make the basketball team. We use it for actual deficiencies like Turner syndrome or wasting syndrome. But here's the catch. You have to monitor for complications like hyperglycemia, and in kids, slipped capital femoral epiphysis. That is a mouthful, but basically if your patient starts limping, you need to get an x-ray, not just hand them an ice pack. I remember this one teenager, he was on somatropin for a legit deficiency, and his mom was so focused on his height that she almost missed the limp. Regular monitoring and patient education are everything. You gotta track growth rates, glucose, and make sure those growth plates aren't closed before you even start. Then there's diabetes insipidus, which is not diabetes like most people think. It's all about water. The brain forgets to tell the kidneys to hang on to water, so we step in with ADH analogs, desmopressin or vasopressin. But, and I can't stress this enough, you can overdo it. Too much ADH and suddenly your patient's a water balloon. Headache, drowsiness, even seizures from hyponatremia. So you're monitoring I's and O's, daily weights, urine-specific gravity, and teaching patients to restrict fluids if needed. Lifelong therapy for some, and you really have to drill in the importance of not self-adjusting these doses. I mean, I've seen more than one patient try to fix it on their own water balance and end up in the ER. Now, let's get into the real adrenaline rush. Adrenal hormone replacement, hydrocortisone, prednisone, fludrocortisone. These are your go-tos when the adrenals have checked out, like in Addison's disease. Here's the thing, you can't just stop these cold turkey. Tapering is a non-negotiable, or you risk adrenal crisis, which is literally as dramatic as it sounds. During stress, illness, surgery, even a bad breakup, patients need to increase their dose. I always tell my students, if your patient's in the ER and vomiting and a history of Addison's, think adrenal crisis first, not last. It's one of my favorite scenarios to teach because it's high stakes, and if you miss it, things go south fast. And then there's octreotide, which is for hyperpituitarism. This one's not about curing, it's about controlling symptoms. Think acromegaly, where the pituitary has gone crazy. Octreotide comes in with its own baggage. Gallstones, bradycardia, GI upset. You have to monitor glucose, thyroid function, watch for the right upper quadrant pain. It's a balancing act, and honestly, it's not the most fun med to give, but it does the job. So what's the common thread here? Patient education and ongoing monitoring. You can have the best med in the world, but if your patient doesn't understand why they're taking it or what to watch for, you're setting everyone up for failure. Teach it like you're explaining it to your grandma. Simple, clear, and with a little bit of sass. That's how you keep your patients safe and your license intact. All right, guys, that's enough hormone talk for today. Next time we'll tackle even more pharmaceutical curveballs. Until then, keep your stethoscope handy and your sarcasm sharp. See you next episode.